Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by Alex Lutz, the VP of Marketing and Public Relations at RUMC, Dan Ryan, the Advertising Director at the Staten Island Advance, and Dr. Alex Barkan, our Chief of Bariatric Surgery and Vice Chair for the Department of Surgery at Richmond University Medical Center. Welcome.
Thank you.
Through RUMC Connections, you will meet the fantastic doctors, nurses, and medical professionals that make our hospital thrive. We'll also provide useful information about your own health, explore the latest medical news, and hopefully get you answers to some of your own health-related questions. The bariatrics field is a medical specialty that explores the study and treatment of obesity through surgeries or other applicable methods. Richmond University Medical Center's Bariatric and Metabolic Institute is operated by knowledgeable medical professionals trained to perform a wide variety of bariatrics procedures aimed at addressing obesity, including sleeve gastrectomy, gastric bypass, bariatric revision surgery, lap band surgery, and support groups. In today's episode, we'll dive into all the bariatric services offered at RUMC. Today, we are joined by Dr. Alex Barkan, our Chief of Bariatric Surgery and Vice Chair for the Department of Surgery at RUMC. Dr. Barkan attended medical school at St. George's University School of Medicine, followed by a residency at Maimonides Center and Hahnemann University Hospital, then followed by a fellowship at University Medical Center of Princeton. Dr. Barkan has performed thousands of bariatric procedures since entering the field in 2006. In 2018, he came to RUMC and founded the hospital's Bariatric and Metabolic Institute. Dr. Barkan has also developed several cutting-edge procedures, including the use of robotics, ensuring that patients receive the most advanced care available. His skills and experience have helped position RUMC as one of the leading hospitals for weight loss surgery in the New York City metropolitan area. Welcome, Dr. Barkan, and thanks for joining us.
Thank you.
So we hear so much now these days about weight loss surgery. So I guess the first question is, are we overweight as a society?
Yes, we do have an issue with being overweight. About 40% of the population of the United States is either overweight or obese, and that number is increasing. And what's interesting is that the number for obesity itself is stable, but for severe obesity is increasing. So the answer is yes, we do have a problem.
Is there a difference between classifications of overweight obese and morbidly obese?
Right. So we use the classification of the body mass index. Mm-hmm. And the body mass index ranges from 18 to 25, which is normal. From 25 to 29 is considered to be overweight. Over 30 is considered to be obese. Mm-hmm. So that's what our basic criteria is to determine obesity.
Mm-hmm. Are you seeing any trends or commonalities, especially for patients from Staten Island?
Well, Staten Island has a large population of patients who will benefit from weight loss and weight loss surgery. There is a large population of diabetics, and about 50% of diabetics are obese. And so there is a definite need to help the community.
Well, we're known, Staten Island's known for having the worst health, right, out of all the 5 boroughs. Yeah. So and obesity is one of those classifications. Mm-hmm. So do you think that's just like a commonality that people have in Staten Island where it's just because of like conditions of living here, or because it's not as metro as the other boroughs, or because we're not walking every day, we're not hitting the subways, we're not hitting public transportation? Do you think that's one of the factors that we have in Staten Island that leads to that being the least healthy borough?
Well, the answer is yes and no, because those factors are in all boroughs to some extent. And we don't really know the exact factors, but definitely a lifestyle plays a role. Genetics plays a role. Some people are predisposed to it. So just because of the population and maybe having lots of restaurants where you can have carbohydrates doesn't qualify you to have more obesity. But it's a factor. For example, there are over 100 putative factors for obesity. One of them is the African mosquito. And the African mosquito can cause obesity as well, because kids don't play outside when mosquitoes are out, so they don't want to get bitten. Or air conditioning could be a source for obesity too, right? Because you're sitting home in air conditioning instead of being outside and sweating things off. So we don't really know, but there are very interesting reasons for obesity, and lifestyle is one of them.
And what's the connection between obesity and diabetes?
So 50% of diabetics are obese. Diabetes increases with increase in weight. And that really is a sort of a direct correlation. Not all obese patients will be diabetics, and not all diabetics are obese. For example, the Asian population has a very significant incidence of diabetes, but they're not obese. And their criteria for obesity are different as well. Our criteria in a Caucasian population would be 30 BMI, and the Asian population is 27 BMI is considered to be obese.
Well, is that based on diet?
We don't know, right? We don't know, because if you have a Asian person who is diabetic but not obese, so genetics definitely plays a role.
Bariatric or weight loss surgery can significantly help in a patient's weight loss journey. Can you tell us about the different bariatric surgeries performed at RUMC and how they differ from each other?
So we perform two basic surgeries at RUMC. We perform something called a gastric sleeve, a sleeve gastrectomy, which is a bit of a misnomer. People think you're actually putting something around the stomach like a sleeve, but it's really your stomach just smaller. And we make the surgery, form the stomach into a letter J, or sort of like a hockey stick, where it's thinner on top, a little wider on the bottom. So that's sleeve gastrectomy. The other procedure we perform is gastric bypass, which, to make it easy, is the letter Y. One part of the Y connects to the new stomach, one part of the Y connects to the old stomach, and where the Y meets, the leg of the Y is where the food starts to be absorbed. So that's the Ru and Y. Lab band surgery is not performed readily anymore. It's more becoming of a historic kind of procedure. It was more common in the past, but it's fallen out of favor because of multiple reasons. One is patients don't want to get stuck with needles to get adjusted. They're seeing their friends lose more weight and faster with sleeves and bypasses, and they don't like that. Plus the complication in terms of slips and erosions and reoperations are up to 30%. And so it's fallen out of favor. Most of the patients we see, we take the bands out, convert to something else. There is an emergent procedure called the SADI, S-A-D-I, which is historically was called a duodenal switch. It's a more complicated surgery in terms of anatomy manipulation, but the SADI has made it more simpler. What you do is you do a sleeve and with a bypass. And what you're doing is sort of pulling up a segment of bowel about 300 centimeters from the connection to the colon, and you're forming a Greek omega. Okay. And you sort of have the sleeve with the omega loop, and that is also another option for surgery that's sort of emerging. And we'll see what that goes.
So, but we're not doing that at RUMC yet. That's something that's...
We haven't done that yet at RUMC, but it is an option.
Okay. If someone had, you're saying that lap band surgery is now kind of like falling to the wayside. If someone had lap band surgery, can they still go for one of the other procedures if they need a
Yes, they do. And we do it in one stage. We take the band out and convert in one stage. In the past, the facilities offer two-stage procedures. We offer one-stage procedure.
And it's evolving. So
it's evolving. It's just because so many people have had the band who now need something else, and so it's available to patients.
And how successful is weight loss surgery in general?
So weight loss surgery is very successful. You can lose up to 70% of your excess weight. So it's very effective for weight loss, and 100% of people lose weight. There is a variability depending on ethnic groups. Some ethnic groups respond differently to surgery than others. They lose less weight. They might regain some weight back. And that has to do also possibly with genetics. But for the most part, it's very effective surgery. If you compare it to medications you can lose 15 to 20%, whereas surgery you can lose up to 70% and higher weight loss.
How long do the procedures take?
So the sleeve gastrectomy take about an hour, and the bypass can be a little longer depending on the situation. So anywhere from an hour and a half to 2 hours.
And how do you determine which procedure works for somebody?
So there are no absolutes, but I mean there are some medical absolutes. For example, a patient who has Barrett's, which is the end stage of reflux, does not qualify for sleeve surgery. Is not a good candidate for sleeve surgery. A patient who is had previous surgery in the past with potential scar tissue does not qualify for bypass surgery because you need a certain amount of bile to work with. So there's some absolutes, but for the patient who is the patient who comes in who doesn't have any history of surgery and wants to decide, it depends on the medical condition. If they're insulin-dependent diabetic, bypass is probably a better option. If they're not, and they're just suffering from the effects of obesity due to hypertension, joint problems, hyperglycemia, sleep apnea, sleep is probably adequate.
And what's the average hospital stay after surgery?
So the average hospital stay is 1 to 2 nights.
That's it.
Yep.
So I see here that RUMC's Bariatric and Metabolic Institute is accredited as a comprehensive center with adolescent privileges by the American College of Surgeons Metabolic and Bariatric Surgery's Quality Improvement Program. With obesity rates continuously rising in the United States, are you seeing an increase in adolescent surgeries?
Adolescent surgery has been pretty consistently on the lower end for multiple reasons, but we do offer the service, and we have performed surgery for teenagers who have benefited.
What's the age that kids qualify?
So in the past, we talked about age, and so the sort of cutoff for the youngest would be as long as their bone plates have fused. But that hasn't seemed to be really clinically a necessity. So I would say we operate as young as 13.
So if you're saying, like you said before earlier, that people lose about 70% of their body fat, I imagine this leaves, for lack of a better way of saying, excess skin. How is that addressed?
So excess skin can be an issue. It necessarily always is, and it's sometimes not an issue as you think it would be. Patients don't complain about it as a major issue. Some will say, what about this? What can I do about this? But it's never to the point where it significantly affects their lifestyle. I mean, obviously, there is patients who start out with a very large BMI, who are super obese, and then they might have a little more excess skin than others. And surgery may be necessary in the future to remove that skin.
And what is, someone might be considering weight loss surgery, what's kind of the criteria to qualify for the surgery?
So the basic criteria is BMI. If the BMI is over between 35 and 40 with other medical issues, that qualifies for surgery. If the BMI is over 40 by itself, that qualifies for surgery. So BMI is the real basic criteria to qualify for surgery. A BMI of 40 is a patient's about 80 to 100 pounds overweight, over their ideal body weight. Very few people have ideal body weight, and it's not necessary to be ideal body weight, but to qualify, you have to be about 80 to 100 pounds overweight.
Can weight loss surgery be reversed?
Yes and no. Sleeve gastrectomy is a permanent procedure because we're removing part of the stomach. Bypass can be reversed technically, but it's rarely reversed. It really very few indications to reverse a bypass, but it can be done.
When you're talking about people that are obese and they're going to have surgery, I imagine anesthesia makes it a little tricky with the body weight, putting someone that heavy under anesthesia. Is that an issue or?
Not really. I mean, no, anesthesiologists who are experienced with anesthesia can easily perform anesthesia on most patients. They do use criteria, something called the Malapati score, depending on the patient's ability to open their mouth, wide the relationship of their tongue to the posterior pharynx, and that may necessitate other equipment to help them intubate the patient, but it's rarely a situation where it's impossible.
Okay. And do you perform a lot of the bariatric surgeries robotically?
We do. We have the access to the robot, and we do use the robot readily to perform bariatric surgery.
And how has that made it easier for you as the surgeon?
Well, for example, we have better visualization. We can get into spaces, tighter spaces than we would be able to laparoscopically with better visualization, better to assess the anatomy. We're able to assess possible issues with tissue better with robotics, and we can perform hand-sewn connections, suturing, easier than with laparoscopy.
And how has the field of bariatrics changed from the first time you set foot in an operating room to what you're doing today?
Well, so, we talk about bariatric, but now it's called metabolic surgery because we really are affecting the metabolism of the human body, the physiology of the human body. So it's become metabolic surgery rather than just bariatric surgery. And it's evolving with the advent of medications. It's becoming sort of turning into like oncology practice where you have surgery together with medicine. And that's sort of evolving. That's where I think the changes have been with the evolution of medications.
Did you start in metabolics? Is that the beginning of your career?
I guess I started when it was bariatric surgery, and it's become, because the society has changed its name from American Society of Bariatric Surgery to American Society of Metabolic and Bariatric Surgery. So that name change happened while I was starting my practice. So it's evolved to what it is today.
Are you finding more and more young potential surgeons are looking to bariatrics as a field to go into? Is it a growing field from a professional side?
It's a growing field from the technical side for a surgeon because of the minimally invasive techniques, because of robotics, because of all the advent of other procedures to help with weight loss. So the technology, and that's exciting for surgeons to be involved in. In terms of choice to become a bariatric surgeon, I'm not sure if that by itself is the reason, but I think it's the technical component for a surgeon. And then that surgeon then evolves into everything else, becomes that bariatric metabolic surgeon.
So when you're going into a procedure you've got the patient on you're going in knowing you're going to use robotics. Is there or do you say, look, I just can't use robotics on this, or is that a decision that's made in the moment?
Most patients are scheduled electively, and so we have to plan. So we'll plan for that robotic procedure. If a patient had extensive surgery in the past, we might not offer robotics as an option because we know there's going to be a lot of scar tissue, or we'll combine laparoscopy with robotics. We'll start laparoscopically to see what the extent of the scar tissue is, and then we'll convert to robotics to finish the case if we feel comfortable that we have enough space to work in.
And you've done thousands of these surgeries throughout your career. What's your game day like when you're going in for surgery?
So again, surgeries are all elective. Patients prepare for months for surgery. Patient doesn't just walk into the office and then get scheduled for surgery. They have a preparation. And when the patient's day comes for surgery, they arrive to the hospital in the morning. We see them, we consent them for the procedure, and they get a certain amount of medications prior to the procedure to help with nausea, with pain after surgery. And the patient then goes for surgery. Anesthesiologist does their part, the nurse does their part, and then when we're ready, the patient's ready and prepped, we then start surgery. And the surgery is done with small incisions. The incisions anywhere from 0.5 centimeter to 1 centimeter at most. They can range from 4 to 5 incisions depending on the size of the liver, depending on the anatomy, and that's how surgery is performed.
And what about you as a surgeon? When like, for example, you're going to work on John Smith the next day, what are you doing the night before, the morning of, to get ready for the procedure? Or is it just, at this point, it's like natural for you to just walk into the room and here we go?
It's interesting. At this point, it is natural. When I was starting out professionally, you have a level of anxiety with every surgery because you are operating on human beings and you want to make sure that things are right. You just make sure you don't forget. Not operating during COVID was very difficult for surgeons because they were just, what else do you do if you're not operating? And also you're concerned that you don't know what to do when the time comes to do it. So that was always a concern. But with the advent of being independent and developing the program here, it's become second nature. And I think the most important thing I think about in the morning is just to make sure I'm careful and to make sure that, we take our time to do the surgeries right. If it takes the extra few minutes, because of the dissection of the anatomy, not to be frustrated and just work through the situation. And I think the safety is the number one thing that I think about.
Do you find that most of your patients are male, female? Is it pretty even mix?
Statistically, it's female mostly, but there's more and more males.
And does that approach change based on the anatomy of whether you're working on a male or female patient?
No, one of the issues with obesity has to do with body habitus and visceral fat. So there's visceral fat and there's peripheral fat. So there are people who are obese, but they don't have a lot of metabolic issues because their fat is mostly peripheral. So women, for example, who have gynoid obesity, who have the heavy set, arms and legs and other parts of the body, they're internally might not look obese at all. Internally, they look like a 25 BMI, 27 BMI. Whereas you have a male who has 35 BMI with android obesity or abdominal obesity and diabetic will have a BMI internally of a 60 because of the internal distribution of the fat. So visceral fat distribution plays a big role in how metabolically obesity is manifested in the patient.
What is the average age of your patients?
The average age is probably, I would say, in the 40s. But I've operated as old as 79.
Wow.
And I've operated as old, I've done a bypass in a 75-year-old, and I think we did a band in a 79-year-old, and she got a tattoo on a motorcycle. So.
Wow.
If a woman has weight loss surgery, is she still then able to have a family, or does that affect pregnancy?
It's not recommended to be pregnant for a couple of years after surgery, not because the fetus is affected, but because the weight loss process is disrupted. Women who undergo weight loss surgeries can get pregnant. In fact, it's easier to get pregnant as well. So as soon as women who had trouble conceiving before surgery lose 30, 40 pounds, and it's much easier. So they have to be careful. They have to use, protection more readily. And potentially, there could be complications of the surgery with pregnancy, with bypass. If there is bowel obstructions, what have you, there has been incidences of fatalities. But for the most part, it's safe as long as you wait that period of time.
Well, I'd like to thank you, Dr. Barkan, for joining us today and for all that you do to keep us safe and well.
Thank you.